Good afternoon. My name is Stacy, and I will be your conference operator today. At this time, I would like to welcome everyone to the Myeloma Update conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. I would now like to turn the call over to our host, Ms. Susie Novus. Ma'am, you may begin.
Thank you, Stacy. Well, good evening or afternoon, everyone. I'm Susie Novus, President of the International Myeloma Foundation, and it's my pleasure to welcome you to tonight's teleconference, Myeloma Updates. Our speaker tonight is Dr. Brian Durie, who will provide you with a comprehensive update on all the important information that was presented at 3 meetings, ASCO, EHA, and IMWG. ASCO is held each year in Chicago, and Dr. Durie and I just returned from Vienna, Austria, where EHA and the 6th annual IMWG meetings were held. So I know Dr. Durie will have a lot to discuss with you tonight. But before I turn it over to Dr. Durie, I'd like to take a moment to thank our sponsors of tonight's teleconference, Bristol Myers Squibb, Celgene, Onyx, and Takeda. Also, please know that the slides for tonight's teleconference call are available on the IMS website, www.myeloma.org. And on the home page, you'll see on the right-hand side, New and Noteworthy. Then, all you have to do is just click where it says Myeloma Update Slides. This call, I want you to know, is also being recorded and will be available for replay on our website. So now it's my pleasure to turn it over to Dr. Durie.
Well, thank you, Susie, and welcome everyone to this conference call tonight. On the first slide, what you see there in front of you is a picture looking across Vienna, which is where the EHA meeting was just held. That's the European Hematology Association meeting, and also the International Myeloma Working Group Summit. And as Susie mentioned previously, the ASCO meeting was held in Chicago. What I'm going to do this evening is to try to summarize some of the major themes that were in common across these different meetings. And so I thought it would be helpful to break this down into 5 different categories. And so if you would go to slide number 2, you'll see that I've indicated what are key questions 2015. And so the 5 topics which I picked to discuss in some detail are diagnostic criteria, new diagnostic criteria for myeloma, a revised international staging system, and new ideas about a personalized medicine approach to the treatment of myeloma, MRD testing, minimal residual disease testing, and response criteria, the challenge of double refractory disease, and basically this is an area of focused discussion about what do we do for patients who have gone through some of the novel agents that we've been using in the last 10 to 15 years, and what new agents are available in this double refractory setting. And a unique topic, one that we have not talked about much until now, is what about the costs of all of these new drugs that we are starting to use, and what about the access to those drugs globally this year and moving forward? And so if we go to slide number 3, diagnostic criteria, I'm going to talk a little bit about what has really been a very important new topic. And so if you go to slide number 4, this indicates the publication which was published in November of 2014. And this is a publication from the International Myeloma Working Group with Dr. Vincent Rajkumar from the Mayo Clinic as the first author, along with some of the major leaders in the IMWG group. And as the pull quote indicates, this paper is very important because it recommends the implementation of these criteria into routine practice. And so this paper summarizes guidelines to diagnose myeloma early and indicates that we are secure enough about these recommendations that we suggest that they be used in the clinical practice for everyday use for myeloma patients. And so if you go to the next slide, which is slide number 5, you'll see that what I've done is give a capsule summary of the criteria which are used to identify patients for early treatment. And those are what are called myeloma-defining events, MDE for short. And the 4 items that are part of these new criteria are tests of kidney function, and up to now we have used the serum creatinine test, which is a simple blood test, and that is part of the CRAB criteria. And if the creatinine level is greater than 2, then this represents a single element of the CRAB criteria. But now we've refined that to indicate a creatinine clearance of less than 40 as a more sensitive way to assess early kidney damage. The second item is bone marrow plasma cells of equal to or more than 60%, and this is actually a small subset of patients, but there are maybe 2, 3, 4% of patients who are feeling fine and don't have any CRAB criteria. They don't have any symptoms related to myeloma, but the bone marrow plasma cell percentages have increased up to more than 60%. And so that now we would accept as a group of patients who are very likely to have problems within the next 9 to 12 months and would warrant early treatment. The third category is those patients who have a serum free light ratio of greater than or equal to 100, and again, this significant elevation in the serum free light chain level indicates a level of disease warranting early treatment. The fourth element I have marked in a burgundy color because this is perhaps the most tricky of the myeloma-defining events to implement. And this is because we are now in the process of shifting from the use of routine X-rays, what we have called skeletal survey, to assess the presence or absence of myeloma bone disease, to use more sophisticated imaging techniques. And the options for this imaging include, as I indicate with the arrow there, MRI, PET-CT scanning, or possibly WBLD-CT, which means whole body low dose CT. Now, for the myeloma defining events, the MRI is what we are recommending be used at this time. And what we're indicating is that if you have greater than 1, so that means actually 2 focal lesions or more than 2 focal lesions which show up on an MRI, this indicates that the disease is active in the bone marrow, and the active myeloma will emerge again within about a year. And so this is a situation where we want to prevent that early bone damage and intervene a little bit early. Now, we're also assessing the PET and CT components. So it is possible to have a positive PET scan, and then the CT can, in addition, be positive or negative. So obviously, if the CT is positive, that would actually mean that there is bone destruction and that the patient would actually have CRAB criteria. If the PET only is positive, this again could be an indication of a myeloma-defining event. If a whole body low-dose CT shows any lesions greater than 5 millimeters, again, this would indicate bone destruction and would actually be indicative of a positive CRAB criteria. So the bottom line to all of this, if you go to the next slide, slide number 6, is that using what is now called this biomarker approach, using biomarkers, which means that instead of looking at are patients having bone pain, Are they having tiredness because they're anemic? Are they having serious kidney problems or other issues? We're looking at these biomarkers. Is the free light elevated? Are there focal lesions on MRI? Rather than the CRAB criteria. This is really a big, big change. It's shifting from the symptoms and signs of myeloma to test results. And this is a whole kind of a revolution in the way that we're approaching the diagnosis and the treatment of myeloma, and it's just the start, because these are the biomarkers that we have now. Moving forward, we strongly anticipate that there will be additional, more sensitive and more specific markers that we will use as a basis for that early treatment decision. In particular, right now, the introduction of the newer imaging is required, and this will have a number of implications. I'll just draw your attention to one of them, which is that if the treatment is started on the basis of MRI, what that means is that the ongoing monitoring will also require MRI, so that whatever is used for the baseline testing will also be required for the subsequent monitoring to assess the impact of treatment. And so this has significant implications for the ongoing management of a patient and also for the costs. And so there have been a lot of discussions which happened at these recent meetings, in particular at our IMWG summit, where several doctors were commenting on how this will really impact the whole way that we manage the disease. So if we go to slide number 7, I'll move into the next area, which is a look at a revised ISS staging system and where are we with a personalized medicine approach to the management of myeloma. And so, first of all, the revised international staging system on slide number 8, and this is very, very similar to the original ISS staging system, which is based on the serum beta-2 microglobulin and serum albumin to divide into stages 1, 2, and 3. The new change is that for stage number 3, we add in the presence of the high-risk chromosome features and or the presence of a LDH, which is elevated. And so that would indicate level 3 ISS with the revised system. And conversely, for stage 1, ISS stage 1 in the revised system would have normal chromosomes and a normal LDH. And so this refinement gives very strong separation of the 3 groups. And if you look at the chart at the bottom of this slide, you'll see that these are very separate, distinct lines of expected outcome for stages 1, 2, and 3. And this is very, very important in the prognostic classification for patients. And so this is a new paper that is coming out in the Journal of Clinical Oncology. It's actually not out yet. It will be published just in the coming weeks, and so you should be looking out for that. On slide number 9, I indicate, well, what is the bottom line for this? Well, the bottom line is that we will be using this routinely in clinical trials. We will be adding in the chromosome and FISH testing results and the LDH into our classification of patients to assess the outcome of clinical trials. But also, this information can be used by the doctor to discuss very carefully with individual patients what the prognostic results would indicate for each patient. And so it's helpful to know what the expectations are and how perhaps treatment might be modified to adjust based on these prognostic findings. And so let's go to slide number 10, where I discuss a topic which has been really a very hot topic this past year, and that is personalized medicine. Now, this is something that sounds wonderful. It sounds like absolutely the way to go. And stratified medicine offers, as I say here, a number of specific advantages for patients. And it sounds pretty obvious. The optimum approach is based on a targeted approach where you study, in the case of myeloma, the bone marrow, and you study what are the chromosome changes, what are the mutations present. You do the testing. You find out there's mutation number 1, which is red, mutation number 2, which is yellow, and mutation number 3, which is green. Whichever one it is, you then select the appropriate red, yellow, or green treatment, and you're good to go. It sounds very straightforward. If you go to slide number 11, what about myeloma? Is this the way to go for myeloma? It certainly sounds great, but is this really feasible? Well, if you go to slide number 12, you'll see that really it's not so simple what we would like for myeloma. And quite a number of studies have now looked at the sequencing of the genes of myeloma cells in patients with myeloma. And as I've circled there at the top of slide number 12, there is no unifying mutation in myeloma. There's no single mutation that is present in all the patients. And in fact, even the most frequent mutation is only found in about 30% of patients. And what we find is that some of the mutations fall into different pathways that may be biologically important. And there are some specific mutations where we may have a treatment available right now. For example, the BRAF mutation, which is present in 4% of patients, and where we do have a treatment available for that. But what one needs to keep in mind is that this mutation would only be present in some of the cells. So what that means is what I have in the bottom box there. There is something called intraclonal heterogeneity, is a meaning which means that there are different clones or subclones where some of the cells would have this mutation and some of the other cells would not. And so if you give the treatment, it could work and get rid of part of the myeloma, but not all of the myeloma. And so if you go to slide number 13, you'll see, well, how did all of the experts who convened at the IMWG summit in Vienna think about all of this? What were they discussing? Well, they were discussing, should the mutation analysis be included in our clinical trials right now? Do we need to be studying all those mutations? Should we do it in the trials? Should we do it in clinical practice? And if so, is there a simple method to study which mutations are there and how do we handle all of that? Well, I would say that there was quite a bit of skepticism about that. And in fact, there was quite a lot of discussion about what I've identified in the yellow box at the bottom, which says that actually, right now, trying to target all these different mutations may not be such a great idea because resistant clones are cropping up and they will require new targeted treatments. And so maybe in some cancers where the mutation rate is much lower and there are single dominant mutations, this can be a great idea. However, if you go to slide number 14, the bottom line for myeloma is that we definitely do need to keep studying these mutations in myeloma and do some clinical trials to see if treatment can be helpful. But this is definitely not ready for prime time yet. We need to look at this and actually study if maybe some alternate ways to collectively get rid of myeloma cells with multiple mutations may be a smarter way to go, and that this is definitely not such a simple idea in myeloma. If we go to slide number 15, an additional question which has been really dominant this past year is about what is the role of MRD, which is minimal residual disease. And so this is a topic where we're looking at small amounts of myeloma which are left after we have very deep responses with the new novel combinations, things like combinations of Kyprolis, Revlimid, and Dex, for example, where we are seeing large numbers of patients who have low-level disease after therapy. And so what is the role of MRD testing? And so slide number 16. There are three critical questions that were discussed at all of these different meetings. One was, how do we define if the MRD becomes negative? Is this something that may be beneficial for all of our patients? And how do we use the MRD status to change the management of the patient? The main thing I would draw your attention to is that these three items are questions. There's a question mark at the end of each one of those statements. And so right now, we're at the point of addressing these questions, trying to come up with these best answers so that we're able to make good recommendations. And so if you go to slide number 17, you'll see that how are we defining MRD negative? Well, the things that we're using are flow cytometry and next-generation sequencing of the bone marrow cells. We have developed a next-generation flow cytometry method, so we actually have next-generation flow and next-generation sequencing, and both of those are part of the Black Swan Research Initiative, which is focused on achieving MRD negative status as a basis to hopefully starting to cure some patients with myeloma. We're also using imaging to make sure that there are no spots of myeloma that would indicate some residual disease. Next slide, number 18. And so these tests are being integrated into new response criteria. And in these new criteria for MRD, we have three elements, of which one or more could be negative. So negative MRD by next-generation flow, negative by next-generation sequencing, and negative by PET-CT. And so the PET-CT is perhaps the least secure right now in that we need to have better criteria to say whether a PET scan is actually positive or negative. We need to have what we call cutoffs to determine the standardized uptake values on a PET scan. And this is, again, something very actively discussed at our recent IMWG summit. And so if you go to the next slide, you'll see that we are transitioning from our conventional complete remission criterion to new response criteria. And so right now, we go from complete response. If you follow the golden arrow on the right-hand side of slide number 19, you'll see that that would normally take us to stringent complete response, where there's a normal free light ratio and no clonal plasma cells, which means no plasma cells typed using kappa lambda typing. And we're shifting from that to say now what we're looking for is MRD negative by flow sequencing or imaging. And if you click forward, you'll see what we are anticipating is that in that process, we will actually replace MRD negative instead of stringent complete CR. So that moving forward, we would no longer be using the stringent CR category in the same way. So what does this mean for MRD testing? In slide number 20, there are several steps to assess and treat MRD. You can see on the left that we have to see, well, what does it mean if the MRD is negative? We still need to understand, do we need to continue with the treatment for a while longer, or is it safe to monitor? And then if the MRD is positive, we need to study that MRD and develop specific therapy, maybe combinations of therapy to get rid of that minimal residual disease. Next slide, 21, indicates that we do have lots of specific targets for the treatment to get rid of the minimal residual disease, and these antigens and molecular targets were things that were discussed a lot at our recent meetings, particularly the antigens, which have all of these different CD numbers that are the basis for monoclonal antibody approaches. And the green antigen dots on the left hand of this slide, number 21, indicate the CD antigens where we actually do have treatments. For example, anti-CD38, which I'll talk about in a moment, that is daratumumab. And then anti-CD319 SLAM-F7 is elotuzumab. And so the ones which are green are ones where we actually already have monoclonal antibody therapies which can be used to get rid of minimal residual disease. And so if we go to slide number 22, you can see that what we need to do is to assess that minimal residual disease and come up with specific alternate therapy, or maybe combinations of novel therapies that can be used to get rid of this persistent relapse-resistant disease. So at the ASCO meeting, at the EHA meeting, and at our IMWG summit, we really focused significantly on the challenge of double refractory disease. And if you go forward from the title slide to slide number 24, what is the definition of double refractory disease? Well, this is a situation which is becoming, unfortunately, more common these days, where we've been using the novel agents now for 15 years approximately. They're not so novel anymore. We have the IMiDs. We have thalidomide, Revlimid, and now pomalidomide, and we have Velcade and carfilzomib. So we have these different categories of IMiDs and proteasome inhibitors. And so patients who are double refractory are patients who are refractory to these two categories of drugs, the IMiDs and the proteasome inhibitors. And so we need now, as a myeloma community, to come up with treatments. And a big question at ASCO and EHA and our summit was, what advances have we got for these double refractory patients? And so if you go to slide number 25, this is a slide about elotuzumab, which is one of the new drugs which is promising for a relapse and refractory patients. And so a very exciting presentation at ASCO this year by Dr. Sagar Lonial was the results of the ELOQUENT-2 trial, which is the use of elotuzumab, which is the anti-SLAM-F7 antibody. And this is an antibody which is used in combination with Revlimid and Dex. And this particular trial, the ELOQUENT-2 trial, is a phase 3 trial in patients who had undergone 1 to 3 relapses. And so half of the patients got elotuzumab plus lenalidomide, Revlimid, and Dex, and the other half of the patients got Revlimid and Dex alone. And what you can see in the middle part of this slide is that the remission duration, the PFS, progression-free survival, was 19.4 months versus 14.9 months without the elotuzumab, so obviously longer with the elotuzumab. And this difference seemed to increase over time, and so at 2 years, the number of patients who were still in remission was 41% versus 27%. And so these data were very exciting, and in fact, at the time of the ASCO presentation, the data were also simultaneously published in the New England Journal of Medicine at the exact same time of the day on June 2nd. And in my experience, this is actually unique. And so this trial is unique in having simultaneous presentation and publication in the New England Journal at the exact same time. So obviously, very exciting to have this new drug available. And so, bottom line, slide number 26, elotuzumab is a new class of monoclonal antibody. This synergy with the Revlimid Dex provides a significant added immune modulation, recruiting NK cells against the myeloma, natural immune killer cells against the myeloma. So this is very important and can provide added remission duration and added survival for myeloma. If we go to slide number 27, the second monoclonal antibody presented both at ASCO and EHA was daratumumab, and so that's anti-CD38. And again, this was presented by Dr. Sagar Lonial, who is obviously the man of the moment in these recent presentations. And this is a little bit different. So in this case, the daratumumab is given alone, and in this case to patients with relapse refractory myeloma. So not the 1 to 3 relapses. These are patients who are in this double refractory category. And so if you look at slide number 27, you'll see that I've highlighted 95% of the patients in this trial were double refractory. But you can also see that a number of the patients were also refractory to pomalidomide and carfilzomib, and so they're reaching the point of something completely new for us, which is quadruple refractory. They're refractory to 4 drugs. And so if we go to slide number 28, we'll see, well, what was the story with these patients treated with daratumumab? And this is really extraordinarily positive and exciting, because the single agent efficacy in this setting was that there was an overall response rate of 29% for this group of patients, with 9% of the patients having a very good partial response, so having a 90% reduction or better, and then 3% actually had a stringent CR. And this resulted in a remission which was at least 3.7 months. And what was quite remarkable is that 65% of these patients who are, in some cases, quadruple refractory were alive and doing well at 1 year. So really a very significant impact with this daratumumab as a single agent. And so bottom line for daratumumab, slide 29, Dara clearly represents a novel and effective treatment, and it does fulfill an unmet need for patients who've really gone through everything. So really a very important finding. If you go to the next slide, slide 30, I just want to draw your attention to another group of drugs where there's a huge amount of discussion at our recent meetings. And these are agents which are called checkpoint inhibitors. And these are words that you just need to start to get familiar with. And these are inhibitors of 2 things, PD-1 and PD-L1. And if you look at the figure on the slide, you'll see in blue the tumor, which in this case would be myeloma, has PD-L1 on the surface. So that's the ligand. That's kind of like the binder for a molecule which is a programmed cell death, which is PD. And then that binds to, on the other side, on the T cell, programmed cell death 1. So that's the thing that binds to the ligand. And so you can block either one of those. What is the normal situation is, through this mechanism, the tumor cell actually shuts down the T cell. And so the tumor cell triggers the T cell to stop working. If you block that, then the T cell is able to start attacking the myeloma again. And so that's why these checkpoint inhibitors are so exciting. And you'll notice in the blue and in the kind of pinkish orange color that there are 5 drugs in each of these categories. So there's 10 drugs right there. This is a very, very active area of research. And in the area of the PD-1 inhibitors, there's one called Keytruda, which is particularly exciting, and this has another name that you may have heard of, which is called pembrolizumab, which is a crazy word, but you should be aware of it. And this was actually approved in September last year for melanoma, but this may turn out to be also good for myeloma. So, to be aware of. The next slide is just to say, well, what are some other options for patients who are in this double refractory setting? We have these exciting new agents. Slide number 32, we do have right now the possibility to use carfilzomib plus pomalidomide and dex. And just to remind you that the progression-free and overall survival with this combination in double refractory patients is really good. PFS of 11 months, overall survival of over 2 years with carfilzomib pom dex in the double refractory setting. So really quite good results. Next slide, slide 33, we also do have the anti-CD19 CAR T cells. Basically, this is taking the T cells from a myeloma patient, re-engineering those to attack the myeloma at the CD19 site, and this has shown some dramatic benefit in a few patients. This chart in the middle just shows a patient who had basically gone through just about everything, and if you look to the right, you'll see there was a dramatic reduction in the myeloma protein level, and this one particular patient, patient number 2, has been in a complete remission with this CAR T-cell approach. So very exciting to see this kind of benefit. And so if we go to slide number 34, I just summarized what are these various promising approaches, the elotuzumab, the daratumumab. We also have the SAR compound, which is another anti-CD38 molecule antibody, which is coming along and will be following right behind the daratumumab. We have the checkpoint inhibitors, selinexor, and the CAR T cells. So several very, very promising agents. The final topic that I just want to touch on before closing, and as I mentioned at the beginning, this is something that we don't usually talk about at our medical meetings. However, at ASCO, there were several sessions on drug costs, and this was for every type of cancer, drug costs and access. And at our IMWG summit, for the first time, we had a focused discussion on drug costs and access for myeloma. And so if you go to slide number 36, you'll see that we discussed where are we with the evolution of treatment for myeloma. We have the old drugs. We have the older drugs. Well, what I mean by that is these are the drugs that we've been using over the past 15 years now. We used to call them the novel drugs, the novel agents, but they're not quite so novel anymore. And then we have the recently approved drugs, carfilzomib, pomalidomide, and very recently the panobinostat. And then over to the right, we have the future drugs, the ones which are coming right along, including some that I've just mentioned, like the daratumumab and the elotuzumab. And so we have this range of drugs, quite a number of drugs starting to show up on this list. So then if you go to the next slide, we'll show you, so how does this all fit together? How does this look in terms of what are we going to recommend for myeloma patients moving forward in the next 5 years, for example? And what are the implications for the costs? And so there are 4 panels on this slide, and so you'll need to click forward onto these 4 panels. So the first panel shows what are called the mild triplets, and these are triplets which include one novel agent plus a cheaper alkylating agent, something like Cytoxan along with bortezomib, so the CyBor-D regimen. If you click to number 2, these are more powerful triplets where you have 2 novel agents together, Revlimid plus Velcade, Kyprolis plus pomalidomide possibly. So you can see the cost of this would be going up along with the efficacy. If you click to number 3, you'll see the triple plus adding in the ELO or the DARO. I just showed you that those are very good new drugs, so now you're up to 4 drugs. And if you go over to panel number 4, and this was presented by Dr. Vincent Rajkumar, what he called the total wallet failure category. And this is where you end up moving into these huge multi-drug combos. Now, maybe they're going to work, but how in the world are we going to afford these combinations? And this was a very, very heated area of discussion at our recent meetings. And so if we go to the next slide, we need to see how does this play out globally. We are extraordinarily fortunate in the U.S. that many of these drugs can be used off-label, and there's really no cap on the costs. But pretty much everywhere else, there are value-based pricing systems. In Asia-Pacific, there's co-pay and limited access. And in the developing countries, really very, very limited access to these new drugs. And it makes it very difficult to be discussing these exciting new drugs to patients where they really just don't have the access that they need. And so to my final slide for my talk this evening before I take questions is, what are the key next steps in trying to solve this problem of increasing drug costs and reduced access? Well, a couple of things I'd like to emphasize. One is that we do need to bring everyone to the table, maybe to a couple of tables actually, and that patients do need to be at these tables. The one table would be one where we're looking at the costs which are directly linked to the costs of treating myeloma. The second table would be where you broaden the consideration to think about, well, what are the other areas where there are costs relating to taking care of myeloma and other diseases. And for example, Paul Richardson, who discussed this topic, he said, well, Brian, we need to consider also the fact that at my hospital we're instituting an electronic medical record system, which for our healthcare system is going to cost $2 billion. And so if we look at the total costs of healthcare, there are many different things that cost money. There's the electronic computer system, there are clinical trial costs, there are all kinds of different costs. And so, yes, we do need to bring people to the table, but we need to have careful discussion to see how we can move forward in a sensible way. And so these are the things that I wanted to bring to your attention tonight. If you go to your next slide, I would like to specifically thank our sponsors who really have been so supportive of helping us to communicate this sort of information. And I would thank you all for participating in this call this evening. And I would turn it over to the operator to can help coordinate facilitate any questions that you might have. And I guess I could turn it back over to you, Susie, first.
Thank you, Brian. That was really great, and I'm sure that many of you probably still have a lot of questions. I know I do. So if you do, please call our toll-free info line. That number, in case you don't know it, is 800-452-2873. The info line is available Monday through Thursday, 9 a.m. to 4 p.m., and on Fridays during the summer, we close the office at 3 p.m., and of course that's Pacific time. So again, thank you, Brian. That was great, and I want to also thank our sponsors, Bristol Myers Squibb, Celgene, Onyx, and Takeda. Okay, Stacy.
As a reminder, at this time, if you would like to ask a question, that is star followed by the number 1 on your telephone keypad. Once again, that is star 1. And your first question comes from Richard Gumtow.
Good evening, Richard.
Richard, your line is open.
Richard's not there anymore.
Your next question comes from Zach Ilo.
Jack Aiello.
Hi, Dr. Durie. How are you?
I'm fine, thank you.
Could you clarify for everyone the new criteria that, first of all, is it replacing CRAB? And second of all, CRAB used to be if you had one of those C, R, A, or B issues. Are there new criteria like creatinine clearance and plasma cells greater in percentage, 60%? Are those ands or one of?
Okay, as usual, a very good question, Jack. And so the first point is that these MDE, these elements that I said, the four things, this is in addition to CRAB. So we're retaining CRAB. So any patient that has the CRAB criteria, they obviously have myeloma and require treatment. And so this is an additional subcategory of patients who do not have CRAB criteria but do have these myeloma-defining events. And so any one of them is sufficient to reach a decision to recommend therapy, so that if you have a reduced creatinine clearance or if you have two or more focal lesions, any one of those is sufficient to make the decision. So sorry that was not clear, but really important points to clarify.
Thank you.
Okay, thank you.
Your next question comes from Siri Shoroff.
Yeah, my question is regarding the MRD methods that are proposed. Between the flow and the sequencing, I have seen the sensitivity mentioned as either 1 in a million, or in one of your blogs it was mentioned even 1 in 10 million, and so on. So as of now, what's the expected sensitivity of both of these?
Okay, thank you for that. So again, very good question. And so the couple of important points. And so with the development of the next generation flow by the Spanish and the Euroflow team using the new cocktail of antibodies and the new software program, the sensitivity of that next generation flow is now down to 10 to minus the sixth, which is 1 in a million. And actually, if you put more cells through the machine, you can even possibly get down to 10 to minus 7. With the sequencing, the sensitivity is in that same 10 to the minus 6 range. And so the important first point is that with the flow and the sequencing methods, the sensitivity is the same. And so then the question is, what are the other pros and cons of those couple of methods? And most of the trials and studies that are going on are actually using both of the methods so that we can compare and contrast and really answer that question based on facts from the trials. But right now, one of the issues with the sequencing is that approximately 12% of the patients were not able to get the results, which is a problem. And then in another 10 to 12% of the patients, we often don't get good binding to the mutational site, so that there are a number of patients where we maybe don't get the results that we want with the sequencing. And then the other is the availability and the costs, and in this aspect, flow cytometry is widely available at many centers, and the cost is relatively inexpensive, costing maybe $100 and $150 for a test. And so these are the things that we're going to be looking at in a comparative fashion moving forward, but trying to assess both of those tests in parallel. Okay. Next question.
Your next question is from John Bianco.
Hi, Dr. Durie. Thanks for the presentation. I just wondered, you didn't speak very much about the
Panabinostat, right.
And so how would that drug be used if someone were using, say, Velcade, pomalidomide, and Dex, and say you weren't doing so great after a while? Would you add that, or would that replace one of the drugs in that 3-drug combination?
Okay, again, a good question. I didn't talk so much about panabinostat because that actually was more discussed after ASH and when it got approved a little bit earlier. But a key point about the panabinostat, this recently approved new drug, is that it works in combination with Velcade best. And so it received FDA approval for use in combination with Velcade. However, most investigators have considered that would be okay to use also in a Velcade combination. And so specifically to your question, it is something that could be added in with, for example, Velcade Dex, with an expectation of, a response and a prolonged remission, but also a Velcade combination, such as Velcade POM. I think that one of the major concerns about the panabinostat did relate to its side effects, where it does have significant side effects, including impact on blood platelets, fatigue, and also some GI toxicities. And so adding it to a more complicated combination could be challenging related to the side effects, but certainly something to be considered.
Thank you very much.
Okay.
Your next question comes from Adrian Bazzini.
Hi, Dr. Durie. Thank you so much for such a wonderful presentation. For a patient like myself that's contemplating a first autologous stem cell transplant, does it make sense in an attempt to get rid of all the types of tumor, all the clones present, to try a CAR T approach in conjunction with the autologous
with a transplant? Yeah. Okay. Good question. And so certainly some dramatic results in the patients with the CAR T anti-CD19. So what I didn't emphasize, 2 or 3 points here. The CD19, that is only positive in about 4% of myeloma patients. So that approach is only feasible for a small percentage of patients. Now, several groups are looking at the CAR T approach to more broadly expressed antigens, which could encompass maybe 40, 50, or even 60% of patients. And so that is something to be considered for the future as a way to eradicate minimal residual disease, for example, after an autologous stem cell transplant. However, I would have to say I do have a little bit of caution. I think that the results in the relapsed refractory patients have been pretty dramatic. However, the CAR T cells do wipe out all of the B cell subclones, which can be great. It gets rid of the resistant ones, but it also wipes out the B cells which make immunoglobulins, and so it does really deplete the normal immune system. And so a number of patients have this problem where they have to get IV gamma globulin to replace the normal immunoglobulin production, and so this is not a trivial issue. And so what we need to figure out is how do we develop a CAR T-cell approach that doesn't have this broad depletion of the normal immune system. So I think that it's very encouraging, but I think it will take some tweaking to be broadly applicable. And so it's not something that we're looking at as a upcoming standard post-transplant. Not right now, anyway.
Right. Thank you.
Okay.
Your next question comes from Jane Blasco.
Hello.
Hello.
Hi. My question is, I've been on Revlimid for about a little over 3 years, and I just became neutropenic, and they reduced my Revlimid down to 5 milligrams.
Okay.
How safe is it to stay on Revlimid alone without remission or a transplant? You know, how many years can people safely stay on that and not have a worsening effect with your disease process?
Okay, a really good question. So the first thing would be that for maintenance, we frequently use the Revlimid by itself. So as a primary treatment, we'll often, give the Revlimid plus the dexamethasone to achieve a response or a remission, but then we use the Revlimid by itself to maintain the remission, and many times we have to reduce it to 10 milligrams or 5 milligrams because of the white blood count or platelets, and but it is possible to continue this for many years, so this is a satisfactory and a safe way to maintain a remission, even although it's not at a zero level, so that there can be a measurable myeloma protein level, there could be a positive immunofixation, there could be a spike which is 0.2 or 0.5, but provided that you're sustaining that with a low dose of Revlimid, this is perfectly satisfactory, and that situation can continue for actually many, many years. And so obviously we monitor for side effects and the like, but this is a whole new area of recommendation, which is continuous therapy versus what we call fixed duration. And so there was a trial called the FIRST trial, which was presented at ASH in December and published in the New England Journal, where the value of this type of continuous therapy was pretty clear-cut to reduce the risk of early relapse. So it's a very reasonable thing to be able to continue with, provided the blood counts are okay or can stabilize.
Yeah, well, they have been. I can't, for some reason, I can't handle the dexamethasone. I was only on it for a couple months, and that was it.
Well, that's okay. And in fact, my recommendation over time is actually to get off the dexamethasone. It's hard to tolerate, and we can use the Revlimid alone as a maintenance. That's perfectly okay. So not to be specifically concerned about that. Actually, rejoice. Off the deck.
I am. Thank you. And thank you so much for clarifying that.
All right. So I don't want to overdo it here in terms of our time frame, because we did set it tonight for 1 hour versus the 90 minutes. So I know that we're getting close to that witching hour. Maybe one more question, perhaps?
Your next question comes from Carol Kellum.
Okay.
Good evening, everyone. Actually, you did already answer the transplant question. I'm getting ready to have a transplant coming up in July, and I had excellent results with VRD. So what is the current thinking on stem cell transplantation, given these new drugs that are on the horizon?
Okay, well, this is a very, very timely question, and there is a trial which is asking that, where patients are getting VRD with or without transplant. And part of the trial is in France with the IMWG, and the other part of the trial is with the Dana-Farber in Boston. And what we've learned is that actually the French part of that trial is being analyzed right now, and we may have an answer to this question as soon as the upcoming ASH. But I can tell you that the sense from most of the investigators is that transplant is still helpful in addition to the VRD, that we get added benefit. And strangely enough, we can see that by looking at the MRD testing. If you look at MRD, you can get MRD negative following the transplant, which suggests that we're getting additional myeloma treatment benefit, and that this will have an impact on remission and survival. So my best guess is that we will end up saying that there is continued added benefit with the transplant. But this is something to stay tuned for the upcoming ASH. We should have the first data on this point.
But it won't be before July.
It won't be before July, no, but I'm giving you my best guess of what it will be.
Right.
So my
well, they had to convince me to have the transplant, and I finally agreed. So I'm going to go ahead because it's the best treatment available to me now.
Okay.
I know there's lots on the horizon, as you pointed out. I appreciate the presentation. It was absolutely wonderful. Thank you.
Okay, thank you. Well, good luck with your treatment moving forward.
Thank you.
All right. So
Stacy, I think we're time for the polling.
So thank you all for your questions, and
stay on the line because you have some polling questions to do.
Okay.
So thank you all, and good night.
Thank you so much for being on the call this evening. And if you have follow-up questions, please don't hesitate to call the IMF or email to the hotline staff. Thank you so much.
Good night.
Good night.
This does conclude today's conference call. You may now disconnect.